Well, hello and welcome to this New Zealand Initiative webinar. My name is Oliver Hartwich. I'm the Executive Director here at the initiative, and it's my pleasure to welcome two guests today to our webinar, Dr. Anne Wyllie and Dr. Crampton. Welcome to you both.
Thank you.
We want to talk about why New Zealand needs better COVID testing systems, and we are fortunate to have you, Anne, with us today because you are one of New Zealand's best experts on this, even though you're not based in New Zealand at the moment, but I'll introduce you just shortly. And we'll then also discuss with Crampton, our chief economist here at the initiative, who's been vocal in debates around COVID and especially around testing in New Zealand. So just as a brief introduction, Anne is, as I said, from New Zealand. She holds a BSc and Masters from the University of Auckland. She then completed a PhD in medical microbiology at Utrecht University in the Netherlands, but she now works as a research scientist at the Department of Epidemiology of Microbial Diseases at the Yale School of Public Health at Yale University. She led the development of Yale's SalivaDirect test, which is authorized for use in the US by the Food and Drug Administration, but that test has also been independently validated in Portugal, Mexico, Ireland, and the Philippines. So once again, welcome, Anne. And Crampton is our chief economist here at the initiative, originally from Canada. He studied in the US. He spent time at Bonn University in Germany before moving to New Zealand, where he was in the end of a senior lecturer in the economics department at Canterbury University before joining the initiative in 2014. So once again, welcome to you both. A bit about the format today. We'll first have a conversation between the three of us. And afterwards, you can ask your questions. Actually, you can already file your questions. All you have to do is you have to go to slido.com and put in the code 466150. You can put in your questions, you can vote on other people's questions, and in the end, we'll take the most popular ones and put them to N. But before we do that, let's just have a conversation. And starting with you, Anne. Earlier this month, you became world famous in New Zealand when you told our New Zealand audience that the Prime Minister, Jacinda Ardern, had not received the correct advice on saliva testing. And you have been active on saliva testing in your academic career. You've researched that, you have started actually with your PhD thesis in the Netherlands, and on your Twitter profile, I see you call yourself the Spit Queen. That's probably the coolest Twitter profile I've ever seen. So before we get to COVID, can you tell us a bit about your academic career and your pathway? What got you into testing saliva?
Yeah, sure. So it was actually the research that my supervisor during my PhD was looking into. So he just loved pouring through the older literature, and there's some fabulous books from the early 1900s. And what they saw that in the early 1900s, a lot of the microbiology research that was being done was using saliva as a sample type. They were primarily doing this with the bacteria that I had been working with pre-COVID, Streptococcus pneumoniae. And for some reason, all of the studies conducted in the present day were being done with nasopharyngeal swabs. So we decided that it could be worth revisiting saliva as a sample type for this bacterial detection and see how that would compare to the gold standard nasopharyngeal swab. So work for my research through my PhD thesis actually identified saliva as a much better sample type for the streptococcal pneumoniae detection as compared to the swabs. And so we've been using that to do large carriage studies in individuals of all ages, just trying to get a better idea of this presence of this bacteria.
So saliva testing for viruses, bacteria, diseases, I'm not a medical expert, has been around for a very long time, I understand?
So while it was being done back in the early 1900s, for some reason in the literature, the nasopharyngeal swab appears post-antibiotic era. It's almost as though when antibiotics were discovered, they thought, everything was solved, we can, move on from this. And for some reason, when this research started back up, the nasopharyngeal swab comes in. It could be to do with the fact that it's very easy to collect that sample type, especially from very young children, if you're trying to figure out maybe what's wrong with young children or study diseases between them. They do have a much smaller nasal cavity. It's also a lot more open than us adults. So even though it causes us a lot of discomfort, in very small infants, it doesn't have the same level of discomfort as we find it. But this is all hypotheses. We cannot actually find who came up with the idea for this, or I haven't dived back into it recently, but when I know a few years ago when I was looking into it, we couldn't quite tell why they transitioned, but here we are.
But because you've been dealing with saliva testing for a long time in your academic career, When you first heard of COVID-19, was your first thought, hey, I can test for that?
No, it wasn't. It wasn't until we were setting up the biorepository at the Yale School of Public Health. I got invited in because I also just happened to have a really robust method of RNA extraction because we deal with saliva samples already for my studies. It's a very, you can think, if you think about your saliva, there's a lot of microorganisms in it. So you want the method of detection to be really robust, really break everything open, find the small, the very small amounts of bacteria that you're looking for. So I had already validated many different RNA extractions or DNA extractions, nucleic acid extraction kits in the lab, and had found the most robust, the most sensitive for working with saliva. It also proved very early on to be more robust when we were just looking at COVID-19 samples as well. The very early ones, like this is early March, we started receiving a couple. We were trying to get this assay up and running. And even compared to some of the other methods that we had, this worked the best. So I was invited to join the biorepository, help lead testing. And that's when we just saw all sorts of problems happen as, worldwide, people scrambled to get the materials needed for testing, the gold standard falling to the nasopharyngeal swabs, the outbreak hitting Italy very hard, very early on, and that's where all these Copan swabs were being made and distributed from. And I wondered if there could be a role for saliva, coming indeed from my own biases, from my own studies and from what I had seen. And I was probably the more junior on the team, so I was also a bit, nervous to sort of speak up or push this too much. But I was also very lucky to be supported by, or surrounded by an incredibly supportive team. So they decided, like, look, let's include it. Let's, include comparing it to the nasopharyngeal swab. Let's put it through. Let's build up a data set. Let's see if there's anything in it, because right now there are so many challenges with this nasopharyngeal swab, with people not wanting to get tested, healthcare workers not wanting to put themselves at risk going in for additional swabs, people not wanting to go back for repeat testing. And so all these things that, saliva can very easily overcome.
So just to get back to the timeline, you said that was in March last year.
That's right.
So that was really at the beginning of the pandemic, when we were still trying to figure out what this virus is and what this disease is. And you were already thinking about testing and you were developing your test. When did it actually get approved then by the FDA?
So we identified the use of saliva very early on indeed. So we actually had our preprint out at the end of April 2020. And that was just comparing saliva versus swabs. So that was with the full RNA extraction process using the Kingfisher MagMax viral pathogen kit and RT-qPCR with the CDC's primer probes. And that gave us the hope for saliva, particularly because we also saw very early detection in asymptomatic healthcare workers, a number of them first testing positive in their saliva sample as compared to their gold standard nasopharyngeal swab. However, we were also appalled at the price of testing. We saw that the biggest barriers were, first of all, a lot of the testing was if you were symptomatic. And then the second was, could you afford it? Because unless you were symptomatic, there was no access to testing, and companies were charging $100, $150, $200 a test. Well, I would sit there often on calls with CEOs, CSOs, and they'd very smugly tell us that they acknowledged that this was a $7 test, a $9 test, but they could be charging anywhere from $70 to $100, $150 because people were paying for it and because they're being reimbursed for it by the government, health insurance companies. And we wanted to develop a test that was more accessible for frequent repeat testing, but also to drive the cost of testing down. And that's what led us to develop SalivaDirect. And then we got emergency use authorization for that on August 15th.
So by medical standards, from what I understand, this is lightning fast. So you write a paper, you develop a test, you get the paper reviewed, you get it published in a journal, peer reviewed. Typically this takes years, a couple of years until you have par at that point. But because of the pandemic, of course, there was urgency, but how unusual was it to get to speed through all of these different steps, including then FDA approval? Have you ever seen anything like it?
I mean, things have happened at warp speed the past year and a half, but I mean, it's also going to mean the people who've made that happen. I mean, we were getting into lab 7 o'clock at night, we're doing our testing. I was often going in to rescue sort of leftover saliva samples at 11 p.m. We'd be sitting there maybe writing, or like all of us just getting onto a paper, starting at different sections, working our way through it. Everyone was just working so hard and such long days, such long hours, because there was a real world need. You know, any delay that we had, or that, you know, or any time that you thought you might want to take off or not work, it's more that has real world impact that could really affect who's going to get tested or not. So it was just an incredible collaborative effort on so many parts from so many people who've just worked. I mean, it's exactly like the laboratory scientists I can imagine in New Zealand at the moment, especially those who have been, especially through the current Delta outbreak and just the hundreds of thousands of swabs that they've been receiving. I mean, I'm sure they really understand just how long those days are and the pressure on you, just, you know, just hoping that it's all going to go smoothly, that you're going to get it right. And you know, maybe even thinking about the laboratory scientists in New Zealand at the moment, that how much of that's actually recognised by the public. You know, it's always the frontline staff are the healthcare workers, but you've got those in the labs, you know, really driving this and making sure that, you know, results get back in a timely fashion.
So you and your colleagues at Yale, you were extremely fast in developing all of this and getting it to market. How was the uptake in the US? Were they also as fast and as ready to adopt your testing method?
They were. So it was overwhelming, and we certainly were not prepared for everything that the FDA threw at us that we would have to start managing ourselves. This is it was declared the most unique EUA that the FDA has offered to date and had issued to date, in terms of that we don't have a product. We have a protocol that we share, that we send labs directly to their suppliers. You know, we don't take a cost, we don't charge anything. We just wanted to have this protocol out there just to help other labs get on board. The uptake, yeah, it was frustratingly slow a little bit at first, and also because we didn't want to sort of overstep and take too much on, or, you know, like allowed us all these labs to come on and try and figure it out. We've just had the 1 year anniversary of sort of the first sort of 4 to 6 labs. We are now at 140 lab sites in 39 states around the country. It is part of
internationally as well, right?
And internationally, yeah, we have less of a count on that. I mean, you know, as you said, being independently validated in these countries, I've learned that through looking at newspaper articles that have come out and then going in to see what the test was, and then seeing SalivaDirect in there, not even knowing that people were working with it. And so there's also a lot of
more countries that you didn't even know about.
Could be, yeah, could be.
Okay, and can you tell us a bit about the test then? So how accurate is it compared to the standard nasal PCR test?
So developing this back in April, we were terrified of false negatives. As you said, we were still only learning about the virus. We didn't know what weak CT values meant. We didn't know at what point you were actually infectious and when you would pose a risk to others. So we wanted to develop our test to be as sensitive as possible. You know, the last thing you want to do is give someone a negative test. They think they're fine. They change their behaviors. They go and see a vulnerable family member, a vulnerable friend, an older individual, a pregnant friend, and, you know, actually they're positive, actually they're infectious, and you know, that can have disastrous consequences. So we knew that so what SalivaDirect is that we removed that RNA extraction step. It is longer, despite what others might say. RNA extraction does add time to the whole process. You can imagine there are more incubation steps, there are more pipetting steps, there are more washing extraction steps than going extraction free. We have a very, very small kind of workup extraction, but it's definitely faster than a full RNA extraction. I can vouch for that myself, having done many of both, and we'll hopefully have some side-by-side time videos coming out potentially. But yeah, so we remove that, bring down costs, bring down time, but we wanted to maintain that sensitivity. So we
just remind ourselves, all of this was happening last year, about a year ago, what you're just talking about. So for a lot of New Zealanders, this is relatively newsworthy, but actually all of this has been going on in the background somewhere else, but not in New Zealand, for more than a year.
More than a year, but you know, New Zealand's government's been aware of it. I mean, we've had direct contact with various members of Parliament, government throughout the year, sending information over, trying to, I mean, I'm aware that there's some comments about, you know, who am I overseas, you know, trying to meddle in New Zealand's response, but I'm a Kiwi. New Zealand is my home. And I just thought that what we learned over the past year, if there was just anything that we could do, or I could do to give back to home to help out, then, you know, I'm spending so much time helping people all around the US do testing programs, develop testing. So why not try to give back to my own country?
I want to bring in Eric at this point, because you were talking about the advantages that the test has, and Eric has had a lot of interactions with our members who are using other tests, of course, PCR tests, and sometimes not have tests available at all. What would be the advantage from your conversations with members and other businesses, Eric, of using such a saliva test?
Well, you hear horror stories, right? So early on, when the government was trying to make testing compulsory at the border, and then especially with port workers, you're hearing a lot of stories around testing hesitancy from port workers who did not like having a stick rammed up their nose a couple times a week. And I wonder whether some of the frequency of testing in New Zealand that followed a weekly schedule just came down to test hesitance by those who are getting a stick rammed up their nose frequently, rather than anything epidemiological on what might make sense for testing in particular risk situations. Here's stories from one business about a worker who ended up with a collapsed nasal passage from repeated swabs up the nose. So it's been a little bit frustrating when...
I think we heard for particular employees in that company who had about 100 tests until the nasal passage collapsed.
So it's been a bit frustrating that accurate saliva-based testing has been available here at least since January. I understand that the Illinois protocol is built on the Yale protocol. They're slightly different, but you guys set up the Yale one, and Illinois built on that, had a few other tweaks to it, and the Illinois version's been available here for some time. It seemed like test hesitancy has mattered a lot, that it has reduced the amount of testing we've been able to do. So it's not just been the monetary cost of the tests and the difficulty in finding skilled staff to administer the tests, to collect the samples, but the hesitance of the workers in getting tested because of the unpleasantness of the test. Now, I understand you've been able to get this out through the NBA and others in very frequent testing regimes. I'd love to hear more about the rollout, like with the NBA, how that's worked, what you know about at-school rollouts. I know that the Illinois protocol is being rolled out to like half of the K-12 schools in the state of Illinois, where they're going to be testing every kid in the school like once a week and potentially ramping it up to more frequent in case of outbreaks. How has this kind of testing method allowed scale up, and how important is that?
It's been so important. I mean, there's some really nice studies, anecdotal data about kids who were in school with robust testing programs were safer and had less infections than kids who are at home during virtual school. And that's because they were there to interact with others in safe conditions, versus if you're homeschooling and you're going out seeking out those social interactions and doing so in more virus risky conditions and getting sick. And UIUC, Illinois, they've done such a phenomenal job. I mean, it really started a homegrown effort there across their entire campus. I mean, they are a model of what colleges around the country should be doing, have been doing, and indeed getting it into schools. The NBA was very, very bizarre, but very incredible. I mean, it really allowed us to show just how well saliva testing can work out in the wild. We gave our collection protocol to one individual. We didn't really take them to it. They're like, here are the instructions. He distributed that between all of the different teams that were still in their home cities at the time. And those who decided to participate, because this was still a research study at the time, they were having their clinical diagnostic testing with their paired anterior analysis. So most testing over here has transitioned from the nasopharyngeal swab, and if not to saliva, to anterior nares AN. So that's just like, it sort of just goes up to here, a little swab on each side. And that was paired with an oropharyngeal swab in the same tube. And, you know, all the saliva samples, I mean, these saliva samples, they were coming back at times, all colors of the rainbow, from, you can imagine, all sorts of sports drinks and other things, but they were the majority, like the vast majority. I think there was a couple of handfuls, literally. It was very, very few that couldn't be tested. And it just showed you like how reliable that the individuals out there could self-collect their own saliva samples, just following written instructions, and return samples that could be tested. And now you have kids that are doing it all over the country. You know, you have either little bags set up that people can just grab as they're coming into class. You know, you can collect your saliva behind your mask, quickly take it down, do it, put it back up, take it home, do it unobserved. It's really easy, and yeah, it's reliable, sensitive, and it's keeping these schools open. You know, there's been questions and comments I've seen about the reliability of it and the sensitivity of it, but you know, first of all, none of these schools are wanting their kids to get sick, their teachers to get sick. The colleges don't want outbreaks. If these tests were not sensitive enough, you would have ongoing outbreaks happening. Many of these places only have testing once per week. You know, we do recommend twice per week for those who have the means to do it. But even at once per week, they're finding positive cases, they're isolating them, and they're stopping chains of transmission. If this wasn't working, these schools wouldn't be in session, many more kids would be sick, and yeah, you would hear about it, but these tests are working.
I just want to get back to what you said earlier, that you are a Kiwi and you want to help your home country a bit in this pandemic. So I just try to imagine how it was for you like that. In 2020, mid-2020, you're sitting at Yale in Connecticut, you're looking from the outside in, you look at New Zealand, you look at our strategy. What were your thoughts? What were you thinking of New Zealand's strategy generally on COVID? And what were you thinking about our testing strategy back then?
To be honest, probably not a huge amount. I mean, again, we were just swamped as it was. And I think it was more because, especially sort of come May, June, I would be almost in back-to-back calls day in, day out with schools, companies, large employers, those in industry, dairy farmers, you know, about potential testing programs. And all I was essentially doing is just giving out testing a device for free. And what really literally brought it home for me was Steph Tan, who reached out to me. She was an incoming Yale MPH student who had also seen the pandemic, but she headed home to sort of see it out a little bit and put her, you know, defer her year. But she saw the work that we were doing. She really liked that. She knew that she was coming into my department. So she reached out to be like, you know, what can I do? How can I help? And she just really rallied up against our, you know, what we were doing. She's pulled together an amazing body of literature to really compare the different studies and, you know, pull conclusions from those. But she was also incredible at reaching out to people all throughout New Zealand, the business network, as I said, ministers, you know, the number of conversations that we've had, and really early on providing testing plans, providing testing protocols that her and I sat down and developed based on the other things that we had, just sort of trying to give these out and be like, this is how you can do it. This is how you can approach it.
What happened afterwards? So there was you. There were other companies also engaged in saliva testing, trying to sell their methods to the New Zealand government. What was the response, and how responsive did you find the authorities here?
There's not really been any response. We did manage to pin one politician down last year because we were really concerned about the level of misinformation going out to the public, you know, talking about swabs, getting confused between rapid tests and PCR, talking about the sensitivity, the accuracy, making out that for some reason New Zealand saliva is different to the saliva of the rest of the world. And actually this individual sat down with Steph and I and was really, really receptive. When we just sat down there and we took them through everything that we've been seeing, what we'd found. And I think they were even just shocked. And you know, they were very receptive coming back to us, double checking things before saying things further. And so it shows that, yeah, that there were some people out there who have been really willing to learn and find the best information, but then, you know, a lot of decisions fallen on deaf ears from others.
So we've got a test protocol developed by a New Zealander at Yale. We have a test that is actively being used in the US, in Portugal, Mexico, Ireland, and the Philippines, but your own home country doesn't show any interest. That was the situation?
From the government level, because obviously there's been some fabulous things done privately. I mean, I do actually now know that SalivaDirect has been validated in New Zealand, and I think the very first time I saw a mention of that, again, I was also very surprised. Much like Mexico, Ireland, Philippines, I didn't actually know that work was going on. But again, it just also shows that when individuals out there have the drive, they see something to take it on and just, you know, recognize that it's something with potential, that, you know, people are willing to do that and, you know, make things happen.
You made quite a few points earlier this month saying the Prime Minister wasn't properly informed on saliva testing. What were the specifics there in where you thought the Prime Minister hadn't received the correct advice?
I just noticed, you know, listening to some of the daily reports, I just noticed that there was a little bit of fumbling. It was when it was, I think, some of the questions from some of the journalists coming in, and it was definitely some unclear answering in terms of, was she referring to rapid PCR testing? Was she referring to rapid antigen testing, the accuracy of different things? And it was just this sort of fumbling over the response that, again, just, you know, it doesn't help instilling confidence into the general public, either about the methods or about, you know, sort of what's going on behind the scenes and what's being done to, you know, improve testing efforts.
Sure.
You noted the importance of validation. How does that work? So you'd said that the Yale test has been validated in New Zealand. If it's been validated in the US, I'm not sure why we're revalidating it here, but how important is that process for any test that winds up being approved? Should they all be validated? What's the protocol?
So we actually have every single one of our labs do a small validation. We ask to see, we call it their CLAIR, the Clinical Laboratories Association. We ask, or accreditation, sorry. We ask to see their data, because first of all, you want to make sure that they've got it up and running, that they've had no problems bringing it on. You know, every now and then I see that someone hasn't diluted their positive control enough, so I can fix that, or they're using the wrong negative control, or I can, one of their internal controls is a little bit off. It gives us that little safety measure to be able to say, hey, something's not quite right here. Let's tweak it before we give you full designation under our authorization, because we want to make sure that these labs are doing it properly. And, you know, I think that's been one of my biggest concerns, is that the saliva is not a traditional diagnostic sample type. And, you know, whether you're implementing a brand new test, whether you're implementing a test that someone else has done, there's a little, you know, little tweaks that have to be made in how you process it. And if your laboratory methods aren't up to scratch with processing it, I mean, again, this can lead to disastrous consequences.
I think we can all see by now how important frequent testing is, especially in an outbreak like the one that New Zealand is currently experiencing. But thinking ahead, once we're all vaccinated, what role will there be for testing, including saliva testing?
That's a good question. I mean, I think, you know, many of us have heard testing's here to stay. I think it depends on a number of things. It depends, first of all, on vaccine uptake in general, because, you know, even, well, first of all, children. And I think not enough thought or attention is being given to children right now, that, you know, this focus on 90%, 95%, however, in whatever number is, you know, over 12-year-olds. But what about those under 12? I mean, we are seeing Delta is different. Delta is not like the early variants that we dealt with. I mean, already there was too much, oh, SARS-CoV-2 doesn't infect children, they're fine. I mean, you know, they weren't. Okay, many were, but when you're talking even about 1%, 2% of cases ending up in hospital, and you really count how many kids that actually is, how are you comfortable in just going, so what? So what if 1% of kids get sick and die from this? You know, like, how are you okay with explaining that away? And this is why I think testing, especially if things reopen and, you know, you might want to protect your schools. You know, it's how what level do you have masks available for? You know, can you be sort of cocooning with testing and having masks or without them? You know, what's going to happen with different variants? What's going to happen with vaccine waning? Do we need to be concerned about that right now? And then just general surveillance, you know, just how much of the virus is actually out there in the population, and just having a good feel for that can help you be able to predict, you know, well, if we've got this much out there, you know, what could be our expected number of individuals who are going to be ending up in the hospitals? What could be our expected death rates if this occurs? So ongoing testing to some respect, whether it's just nationwide surveillance or, you know, still protecting more vulnerable members of the community, is going to remain important.
Thank you.
One of the things that I would love to see in MIQ here, and we should have been doing this, I think, for rather some time, we had very frequent saliva-based PCR testing of everybody in MIQ, and not just the couple of times that they're in, but daily or near daily testing. We'd have a far better data set about the likelihood that somebody's who's coming in, so if they've been vaccinated or not, whether they did the pre-flight test or not, because the conditions on that have varied. We get a much more complete picture of the risk profiles that are presented by different types of travel into New Zealand, and that could really start informing changes in MIQ practice, right? Because otherwise we're just flying blind. Well, maybe it'll be a week, maybe it'll be 3 days. You have to do that in its own way, right?
You're completely right. I mean, first of all, me coming as a more academic researcher, I mean, it's such a lost opportunity to have an amazing study to learn about this. But I mean, you could have already learned so much about viral dynamics. I mean, first of all, if you'd had more frequent testing, and I mean, I've actually been through MIQ. I was really, really lucky to do that last year and come home and see my family. But, you know, a day 2 test and a day 12 test, and seeing some of the, there were a number of pockets of risks identified. I mean, I saw it, like who you'd pass in the hallway. That'd have us all waiting in a room for a daily health check, and to points where I'm like, I don't want to wait in there with everyone else. I have survived too much throughout this pandemic, coming home to see my family, to risk sitting in a room with like a bunch of other people to go into a daily health check to see whether, you know, that, you know, I think everyone does know that there's been outbreaks, cases of transmission within MIQ, and having that 2 to 12, it's too far away. I mean, there should have been tests earlier to begin with to make sure, but by now you could have potentially learned by day 9, you know, a PCR test at day 9 likely clears you through days 10 through 12. Could everyone be going home at day 9 or 10 knowing that you'd not had outbreaks, or going home to a more self-isolation and saving, you know, 4 days of MIQ, 5 days of MIQ per person? And that's a lot in terms of the number of people who are trying to get home, and also the amount of money that the government is spending on this.
Yeah, it's just such a lost opportunity.
Yeah, we should probably get to the Slido questions now. Just a reminder, file your questions on slido.com. Code is 466150. The most popular question right now, though maybe slightly off topic, what are Dr. Wyllie's views on robust and sensitive rapid antigen testing?
So that's an interesting question. That's an interesting question, because it's the sensitivity that's the issue. And unfortunately, there are very few antigen tests that have, antigen tests have not proven to be sensitive enough for many different settings. There is a time and a place for all testing, and I think it's actually really important with, you know, New Zealand getting these rapid antigen tests to trial, that I already think it's time that the public is also really informed of the capabilities of antigen tests and not, because you know, as encouraged as I've been to see everyone jump on the saliva bandwagon, you know, I think it's, you know, still also been a bit confusing at times. Is this a PCR test? Is it a rapid test? Is it a sponge? Is it, you know, but the problem with rapid antigen tests is that, yes, they detect someone when someone is infectious, but that means you're going to be constantly chasing your tail. You've found someone who's infectious. They've already been out and about infectious. And so who's next? You've got to find them when they're infectious. The thing about PCR testing is that it is sensitive enough to detect individuals before they're infectious. And that's the important thing. And it's not even if you're just going for zero COVID or elimination, this is going for outbreaks in schools, nursing homes, hospitals, that you want to get ahead of the curve by finding people before they're infectious. That's not to say that they don't have a use. They are fabulous, obviously, for if people are arriving at a testing center and they've got, you know, signs of illness. So if you're infectious, you're most likely to have symptoms, because that's infectiousness, symptoms, that's when you've got high viral load. And this is when these tests work. So, you know, if someone was at a testing center, they've got symptoms, you can quickly screen them. Is it actually COVID or is it not? Great for, you know, if you do have cases in the community and you're wanting to protect your hospitals, because of course hospitals, as you said, even when there's vaccination, widespread vaccination, hospitals are full of vulnerable individuals that you probably don't want outbreaks in hospitals. Even if all of those individuals are already vaccinated, they're in hospital because of other reasons. So, you know, having rapid antigen tests on arrival at a hospital. So first of all, you can let them in, know whether they're infectious or not, but still take a nasal swab, take a saliva sample, send it away for PCR testing, just to make sure that there's nothing else lurking below the surface of that rapid antigen test. They are being used in other settings overseas. They sort of give you a window of anywhere between, depending on the test, sort of a 2 to 6, maybe 8 hour clearance of, we can be sure that if you're negative here, you're not likely to be infectious in this next window. So if you're going into an event, for an example, and especially for those who potentially can't get vaccinated, won't get vaccinated, if a test is required, then this can be like, you know, your pass for the next 2 to 4 to 6 hours. It's really important not to rely on these too heavily again, though, because again, a negative test can change behaviors. This has been seen with sports teams in the US who at first relied on rapid antigen tests. They were daily tests. These kids were having negative tests in the morning, thinking that they were negative, you know, go about their practices, school, and then being sports stars, were very, very social creatures, go out to all sorts of parties, come in the next day and test really hot positive, and they've been infectious at these parties, and outbreaks were happening around campus because of it. When you have PCR testing, that's less likely to happen. So you just be mindful, really, really mindful about the use case for them.
So there are pros and cons of these rapid antigen tests, as you explained. But do you think the cons outweigh the pros so much that it's correct to have them illegal in New Zealand? Because right now you can't even import them into the country without risking a fine.
Yeah, I just learned that. It was really interesting. I think there's some, I think there's some level of good responsibility there, because again, these tests can change behavior. And so there's two things. They have a much higher false negative rate, but they also have a much higher false positive rate. False positive rates probably aren't so bad, because it just probably means it's going to flag people who aren't actually infected for follow-up testing. So they probably will just need to go and get a PCR test. But, you know, if you were to test, sorry to just digress a little bit, for example, but say the same thing, if you were going to test an entire plane as they're coming into New Zealand with a rapid antigen test, just to find who's infectious, who needs to be quarantined in MIQ immediately, you know, who around them should we maybe be more mindful of. This will tell you who's infectious. You might have 1 or 2 false positives in there, but at the same time, they're probably going to be flagged. And instead of testing, you know, a plane load of 400, 600, 700, whatever people by PCR, you've managed just to do these rapid antigen tests and maybe send away 3 or 4 PCR tests. So they can be really useful for preserving laboratory capacity, the costs associated with that, the time associated with that. So, and now I've forgotten the original main question.
Oh, well, actually,
I've got a use case for you, Oliver. So the way that I've seen these fitting into what we already have is as a complement. It would be dumb to take them as a substitute for all of the reasons that you pointed out. But we have currently essential workplaces operating in Auckland. You've got like 500,000 people working in Auckland despite restrictions, and they might be getting a weekly PCR test at most.
Yeah.
Actually, this links up quite nicely with a question from Barbara. Probably answered it, but I'll just ask you for clarification. What's your view on pre-testing before flight? Could a pre-test be negative, but 6 hours later, a person may have built up more of the virus and be positive? So I understand. Yes.
Yeah, so again, it depends on the test that's being used. I hate the 3-day before departure test as well, because 3 days before, also who knows what you've done in that 3 days before you're getting on the plane and how that changes. This has been like another idea about rapid antigen tests, that say if you're flying domestically throughout New Zealand, then chances are if you're having the test and you're negative, you're going to be fine for that. Going to across to Australia, you're probably going to be fine from that. Going any further afield, exactly as you suggest, you may have built up too much and you could actually become infectious during the flight.
That gets back to the complement idea, right? So there was a trial between the US and Italy where they had the standard 72-hour PCR test, followed it up with a rapid antigen test at the airport before boarding. Out of 10,000 travelers, they found 4 positive, stopped them from boarding, and then they found another 1 positive on a rapid test on landing in Italy. It'd be nice to see those kinds of layered protections more broadly here, right? So keep the standard PCR, add in some rapid antigen tests, like before boarding a plane or between PCR tests at essential workplaces.
Exactly. I mean, I think, sorry, going back to the actual original question before, was that just testing options matter, having the capacity, having backup, having things that suit different settings, suit different people. But I mean, you still want to be mindful about making sure your test is well suited to that. But indeed, just sort of diversify the pressure, diversify also the local buy-in and also the local economy in these different, test approaches as well.
Okay, question for you, but probably also for Eric. Has it been up to businesses to introduce saliva testing independently of one another, or has the government introduced guidelines for employers?
Eric, do you have a...
I can give what bits I know. So I know that Air New Zealand has contracted with RACO to do the Illinois-based test. That's a private arrangement. RACO is validated to New Zealand standards. It's done a good job on all of that. I know that when they were looking at people crossing the border between Auckland and the rest of the country, like transport companies were being directed to the government's preferred Asia Pacific Health Group for saliva-based testing. I know less about how their test runs. So it's sort of a mix. When it's pure private, then people have been able to go with RACO. When the government has been involved, then it's kind of pushing towards Asia Pacific. I'm not sure what more you might have on this.
Yeah, I mean, I know that there's definitely been some local buy-in to sort of utilising private labs in New Zealand, and same overseas. I think it comes down to the companies. I mean, they are looking after their employees, showing that they care for their employees, doing what they can to help. Sometimes over here, more in the US, where it's obviously been worse, it also comes down to, maybe there's a high cost to set up testing programs, but what are your costs if you have an outbreak? A number of people have to go off for 14 days, you have to stop production, or the associated maybe bad press from that. So it's sort of sometimes outweighing how much are you putting into this versus what you can actually save if you were to, prevent outbreaks from happening.
Mm-hmm. We've got another question here, and it's another clarification question. You've touched on this before. Someone wants to ask, how effective are saliva tests when compared to nasal swabs, and is there a difference in false positives or false negative results? So if you compare them side by side, how do they perform?
So that's actually a really interesting question. It's a little bit twofold. It's both sample type and the method. So for anyone who's had a proper nasopharyngeal swab, you've probably had quite the irritation at the back of the throat. I personally get a bit of burning in the back of my throat for the rest of the day. And then you have others who say that it didn't really feel anything. I've actually even had one person saying, don't worry, I'll be gentle. And indeed, she really was. I could barely feel it. If you're not feeling it, if you're not having discomfort, the swab is being done wrong. They're not picking up enough material. And actually, this is what we saw when we did our side-by-side study of nasopharyngeal swabs and saliva samples. You can look at the results. So when you do your COVID testing, you also target a human gene. And it tells you how much material is in the, how much material you picked up, how much material is in there. And you can see that on nasopharyngeal swabs that they're sometimes very low. Or if you look at some people's infection patterns with nasopharyngeal swabs, they can be positive one day, negative the next, positive the next day, negative the next. And that's not infection dynamics. That's not how it works. that can show that the swab is not taken properly. And so if anyone's not, I even saw on Twitter from some New Zealanders recently saying like that was the most pleasant swab they ever had. And I sat there feeling, well, that's not necessarily a good thing. So yeah, so first of all, it's sample type, making sure it's taken properly. I mean, it's much easier to see that there's saliva in a tube. In terms of exactly, and then because you're testing for the human gene, you can make sure that it's actually human saliva and not sort of some water from the tap, and also you'd be able to tell. But then the other thing is method. There's not one method type being used. People are trying all sorts of different methods, and where a lot of the misinformation regarding saliva is coming from are from studies that are taking their method for swabs. They're applying that to saliva, hoping it works. And when it doesn't work, they blame saliva rather than blaming the method. You know, you wouldn't take a urine sample, a blood sample, process it by that same method, expect it to work, and then blame the sample type. They're different samples. And so this is what I've been trying to really highlight as well, that it's really important that you can't just take your method that you have for swabs and apply it and expect to get the same results. I mean, this is why you do have to do your validation. But also you can also look at a lot of the methods that are being done all around the world and which ones have worked, which ones haven't worked, and really focus in on those. So this is, sorry, a very long way of saying this. In the end, if you're using a good method, there are an increasing number of studies that are showing that saliva, you can really detect the virus very early on in saliva, even before the swabs. And I mean, that's exactly what I saw in March last year with our asymptomatic workers. We thought something had gone wrong with our test. We were getting people who are only testing positive by their nasopharyngeal swab 2 to 3 days later, and they were positive in their saliva. It's what happened at Tokyo this year in the Olympics, positive in saliva a couple of days before the swab. So this is happening. So it shows that it can be a really reliable sample type.
So they're better, they are more comfortable, they're probably cheaper, they're easier to administer. So what's not to love?
Exactly.
Are you in
any cons?
Definitely some individuals struggle with saliva production. Typically, a lot of people will struggle at first, but once you start doing it regularly and you get into the habit of it, you can get over your stage fright, you get over how weird this is, or as you're walking in to take your test, you're already pulling some saliva in your mouth. But there are just some individuals that for some reasons, if they're not very well hydrated, or sometimes due to medication that they take, it can be harder for them. So this is again why it's important to have options. That, you know, I went to a fabulous testing site recently there in Colorado, and they've been testing essentially all the kids in Colorado. And you come into the site and you can say, do I want a saliva test or do I want a nasal swab? And people will choose. And again, having the options, you're just going to get more buy-in because, yeah.
Okay. Next question here. I'm not quite sure whether I understand what the question is about, but do laboratories use pooling of samples as a strategy with the SalivaDirect method? What pooling of samples could it be?
So not officially yet. So pooled testing is when you take a group of samples and you combine them into a single sample, and then you process it as a single sample. If that pool tests positive, you go back to the original samples and you test them all individually to try and find your positive one. So pooling is a fabulous method, especially it's an interesting use case in New Zealand's response, because you can imagine if you're putting samples together, you're going to dilute out a potential positive signal. So it does affect the sensitivity when you pool. You will get a decrease in sensitivity. And so you do need to be mindful of that, but especially, as you said, once things reopen, you know, maybe doing more of a surveillance, you might miss some of the very, very low viral load ones. But it could be a good way to be more cost effective. So people are doing some incredible pooled saliva testing. There's a lab in Brooklyn here called Miramis, and they've been testing schools all over the Northeast and beyond, like hundreds of schools, and they pull 24 saliva samples, but they do that with RNA extraction. I've just seen that there is a paper about to be published on pooled SalivaDirect, which again, it came across my desk. It came across my desk unofficially. I had no idea it was being done, but they've done a whole testing program at their college here in the US using pooled SalivaDirect, and we've actually also validated it. We've got an amendment in with the FDA at the moment to have 2 different pooled testing workflows, again recognizing that different labs have different protocols in place, different ways of doing things. We're putting 2 different pooled testing approaches, only up to 5 samples on ours, because we do test a smaller amount. Again, just wanting to maintain sensitivity. So we're only doing pools of 5, but again, you can imagine that still bringing that price down, allowing more samples to go through.
Just a question actually for clarification. So do you pool random samples from random people, or do you pool people from a single setting, from a household or from a classroom?
You can do both, you can do either. So again, this pooling is happening in the lab. So you have all of your individual samples are still going to the lab, and then they're doing on-site pooling, because that way they can go back to the original sample type. There are some schools, they can do pod testing, they can put them all together. It really depends on where these labs are receiving their samples from and how they want to do it. But yeah, you can do either.
Okay. Next question. Do employers need to do spot tests of employees to make sure they are not misrepresenting results? Interested to learn about checks and safety.
It's a really interesting question, and especially when New Zealand was going for the elimination strategy originally, you are putting a lot of trust in individuals if you were moving them to doing their own tests and like doing them properly, reporting them properly. I mean, when you had elimination, it was a lot of faith put into individuals to make sure that everyone was really on board with that and going to do it properly. But I mean, at the same time, in the end, the amount of resources that it saves, and the fact that you do have some checks and balances, again, you're testing for that human gene, so it's not just some sort of random sample coming through. I mean, there's some cases where someone says, oh well, maybe someone else in the household will submit their sample instead of you. I'm like, well, chances are if you're all in the same household together, if one of you is testing positive, the other one probably is as well, unfortunately, or likely to at some stage. So it's at some stage, you've got to sort of open it up, trust people, trust them to do the right thing, get them on board. Again, if people understand the consequences of not doing it properly, the risks that have, or the penalties that might be surrounding that as well, then maybe it can help. I mean, there are, literally millions of people around the world right now sort of like self-collecting samples at times, sending them away, doing their own testing, that, hopefully in New Zealand it can be done the same.
We've got a technical question here. What's the current cycle threshold rate set at for COVID-19 PCR testing in New Zealand labs, and will the same rate apply to saliva-based PCR tests?
So I actually don't know what they're applying in New Zealand. Common CT value thresholds are around 40. I know in our SalivaDirect protocol, we have between 37 and 40, depending on the instrument that is used. I know that there's a lot of, I think it's really just important to state, in case anyone has any doubts, is that the PCR test is highly specific for virus RNA. So if you are getting a positive result, you are positive for virus RNA. I know, and it is a sign of infection. There's a lot of misinformation going out about PCR. I'm sure a lot of you are familiar with it, whether you subscribe to it or not. I'm telling you, PCR testing is reliable for virus detection, virus RNA detection. There is a case that the nasopharyngeal swab picks up historic cases. So what happens is, I wonder if this question about CT values is because at what level do you cut it off and what is clinically relevant? Because it's usually maybe around more the range of 28 to 32 that an individual becomes infectious and contagious, which is why you want to have it down to 38 to 40, because again, you're wanting to detect people before they become infectious. The problem is the trail end of infection. So, your viral load comes up and then it will peak and then it will come down. And what we're actually seeing in saliva and anterior nares swabs, so again, the shallow ones, is that your viral load actually comes down faster. But then I think, as everyone's probably heard, as the cases reported from the border, is the evidence of historic cases. And then there's a lot of times that you'll hear, like, if you've tested positive in the last 90 days. This seems to be more of an issue with nasopharyngeal swabs, and it could be to do with something that massive proliferation, so massive replication of the virus, the back of the nose. The older, especially in older individuals, the nasopharynx respiratory area can be more dry, thicker skin, and it takes you a little bit more longer to sort of shed that skin and replace it, whereas in your mouth, sort of all your cells, I mean, if you're just thinking about how much saliva is passing through, it's being constantly renewed. And so what we're seeing is that actually the shallower swabs and saliva might be, and also if you look at a lot of paired studies, if you come out sort of 10, 12, 14 days post-symptom onset, you see more of a discrepancy between saliva and swabs. So it's sort of showing you that saliva is better reflecting the true clinical stage of infection. So you still detect it sometimes earlier or very, very early on, but then as your virus and your infection actually clears, it actually clears out of the testing faster than having these historic cases. And I think what's important about that is because you want to be able to get people back into their jobs, back into the community. I mean, very early on, I mean, I think I got a call from a firefighter. I don't know how he got my number. I was walking into the lab and he's like, I've been testing positive for 6 weeks now. And again, this was very early on. We didn't know about, you know, can they go back after 12 days, 14 days, despite the fact that they're still testing positive? I'm like, I really don't know. But, you know, he was off work. We had healthcare workers who, once they had tested positive, they refused to do any more testing because if they tested positive again, they didn't have any more sick leave. And again, it's just because they were getting historic shedding. In the end, coming back to CT values, once we had cases and we had our healthcare workers going in and we knew that they'd been positive, we looked at those viral loads and those from the swabs. And again, the same thing, that if someone's constantly positive at that very low level, sort of 35, 36, 37, 8 for a very long time, you know that's historic shedding, because if it was true infection, it's going to come up and then be cleared.
Okay. Most popular question right now, some countries are testing for antibodies, immunity, rather than looking for the virus. Is this something New Zealand should consider in its border arsenal?
Testing for antibodies is a tricky one. Because of the way, again, that your antibody dynamics work post-infection. So testing for antibodies could be really interesting right now in Auckland. And that could be, you know, again, we've actually been investigating antibody detection in saliva as well, because, you know, if you can take one sample, test it for both present infection being RNA and testing it for antibodies. So I know that there's also a massive vaccination campaign, but you're being vaccinated against the spike protein, so only one of the regions. So you can actually test for your antibodies and look at different proteins of the virus. So then that way you can determine, is this just antibody response are you seeing, or do you have evidence of past infection? And it could be a really interesting, and was this done early on in New Zealand as well, maybe? But if you just do a large sero survey, especially quite close to an outbreak, you can maybe get an idea of just how large the outbreak actually was and how many cases went undetected or not. And maybe even help like fill in some of those gaps between, but again, this often requires blood testing, which again, you know, if people aren't wanting to get nasopharyngeal swabs, getting people in for blood testing is not going to be easy or cheap. But again, if it's something that you could do with saliva, but again, that's more for research, policy, development, you know, knowing how much it is. It doesn't really tell you much about current infection, but it can be important for knowing about vaccination status and vaccine waning. But you also have to remember that these tests, just because you're negative or have a very, very low antibody response, doesn't mean that you still don't have a good reservoir of antibodies in your body, because that's the idea, is that they go into the reserves, they go into wait until you are challenged with the virus again, and that's when they really come out. So this is why antibody testing can be a little bit dangerous at the moment, just because we're still learning again about like what levels do we actually need to have to know that we've got a good response, and we don't want to worry people that they don't have a good response, but we're going to be learning more about that. So it's still a little bit of a tricky one.
Well, we're coming to the end of our session, but before we conclude, I would like to ask you one final question. If you had a wish for things to change in New Zealand's COVID response and pandemic management, what would you do? What is the one thing that you think we should be doing differently in the future?
I really think they need to listen to scientists. They need to listen to scientists, the laboratory scientists who are on the ground, the medical scientists in the lab. They need to listen to epidemiologists, academic researchers. I mean, I was appalled to learn that, you know, the Ministry of Health didn't have an epidemiologist on staff prior to this. And still a lot of the people who are involved with making the high level decisions right now are not scientists, are not researchers, are not, you know, of the medical profession. And, you know, that really has, you know, massive implications for how much these people know, how well informed they are, the connections they have, or even the way that they usually approach situations. You know, scientists are trained to be very critical, troubleshoot, think about these things, look at things. So I would really hope to see that, you know, yeah, that there's maybe a change and that you see more, whether it's more scientists on board or more collaboration, more open conversations with those, you know, not even, you know, they don't have to talk to me, they don't have to talk to anyone abroad, or maybe they should, to learn more. I mean, again, to learn more about others' responses, but even just starting at home, having more people with scientific backgrounds involved in what's going on, especially in public health.
I think that's a very good note to end on, and especially if they are looking for a properly qualified and very eloquent scientist. I have an idea of someone at Yale. So with that, and thank you very much for your time, for sharing your thoughts with us today. And thanks everyone for your questions, and indeed to everyone who contributed great questions and slides. Sorry we didn't have time to go through all of them, but I think we had a very good discussion, and I think we've learned a lot. So thanks, Anne, thanks, Eric, and thanks everyone for watching, and see you next time.
Thank you very much.
Thank you. Bye-bye.
Bye.